Good afternoon, everyone. Welcome to this oral presentation session, which I'm going to be chairing. My name is Amos Fatokun, and I'm from Liverpool University. But before we start, can I ask if Mr. Ryan Duffy is here? All right, he's okay. So once again, welcome to this session. This is oral presentation 5, in case you are in the wrong place, but we hope that everybody is in the right place. And we have got 6 fantastic speakers for this evening, and I believe that we are all going to really gain from the knowledge that they're going to be sharing with us. Before we start, just to say thank you to all of the Pharmacology 2024 sponsors and partners, and we want to encourage you all attendees to try to attend so that you see some of the things that they have brought. So if you are having lunch or you are having a tea break, we encourage you to please go to their booths and talk to them. Thank you to all those sponsors. Now, our first presenter is Mr. Ryan Duffy, and every presenter is going to be talking for 10 minutes. Once you go over 10 minutes, I'm going to give you a warning, and I will have to stop you once you are 2 minutes beyond your given time. And there is going to be a time for questions and answers. So we've got microphones on the highs if anybody wants to ask questions. But you can also type your questions into the app. So our first speaker is Mr. Ryan Duffy, who is a PhD student in molecular pharmacology and drug discovery from the University of Nottingham. And Ryan will be talking this evening about the tropomyosin receptor kinase C, that it has distinct spatiotemporal dynamics compared to TrkA and TrkB. Over to you, Ryan.
Thank you very much for that kind introduction. And so just to reiterate, my name is Ryan Duffy. I'm coming towards the end of the first year of my PhD at the University of Nottingham. And today I'm going to be talking about TrkC and its distinct spatial temporal dynamics. So first of all, should we define what a TrkA receptor is? So it stands for tropomyosin receptor kinase. It's a type of receptor tyrosine kinase, an RTK. And if you were at this morning's RTK session, you'll know all about them. So I'm going to give a brief introduction into what they are. They are a neuronal RTK, and they come in 3 main forms: TrkA, TrkB, and TrkC. And they all, in their own ways, regulate the survival of neurons. Then they do this through their kind of extracellular domain, which is where our ligand binding occurs. We have a singular transmembrane domain, and we have an intracellular region, which we find the kinase domain. And so one of the main ways that they're able to do different functions within the body is through their expression. So TrkA is thought to be the mainly peripherally expressed TrkA receptor, and TrkB and TrkC are both thought to be mainly expressed within the central nervous system found throughout the brain and the spinal cord. And to give some clinical context, TrkA receptors are now thought to be downregulated in Alzheimer's disease, and many groups are now looking to bolster TrkA signaling in central degenerative diseases. So now a quick look of how the pharmacology works with these receptors. Each of our receptors is thought to have a canonical ligand. These ligands are dimeric in nature, and they can induce signaling of our various receptors. So TrkA's ligand is NGF, nerve growth factor. TrkB has BDNF and NT4 as its canonical ligands, brain-derived neurotrophic factor and neurotrophin-4. And then finally, TrkC has only neurotrophin-3, NT3 as its canonical ligand. And so what I'm going to be talking about today is kind of 2 steps of this pathway from receptor binding to signaling. So our receptor dimerization, our monomers, as you can see in the membrane here, they dimerize upon ligand binding, and then also receptor trafficking. So how do our receptors then internalize and then have functions intracellularly? So again, if you were here at the RTK session earlier today, you'll know all about this technique BRET, known as bioluminescence resonance energy transfer. And basically what this technique utilizes is the ability of a donor bioluminescent enzyme to transfer energy to a fluorescent acceptor. So on this example here, I've got a TrkB monomer that has an N-terminal nanoluciferase donor, and then also a TrkB monomer that has a fluorescent snap tag, which will be tagged with 488. fluorescent dye. And so at rest, our monomers kind of exist as monomers. And then when we add in our BDNF, we're expecting a dimerization response. And then this means our donor and our acceptor come into very close proximity of one another. And when they do this, we're able to measure a response, a fluorescent response from our fluorescent acceptor. And then this is what we know as a Brett change, a change in Brett here. And so on this graph, we can see at time 0, which is when we added our BDNF, we see a very profound increase in our Brett, which is indicative of our constructs moving closer together. And in this case, we can say that this is a dimerization response. And we also tested this in a range of different concentrations, and we can quite clearly see from 1 picomolar all the way down to 30 nanomolar, there is a nice dose response of BDNF dimerization in this example. And the final kind of parameter that I wanted to look at was a concentration response curve. So to do this, I've taken the area under the curve of the dimerization data and then plotted this against log ligand concentration in mole. And so I think the first thing to do was really understand this canonical relationship that the TrkA receptors have with their ligands. So the first idea was to do some real-time dimerization with NGF TrkA, BDNF NT4 with TrkB, and neurotrophin 3 with TrkC. And that's represented here on each of the graphs on the left here. And as you can see from this data, each of our canonical ligands is able to produce a fairly robust dimerization response in its own canonical receptor, which was good to see. And we can also see that this is a dose response in all cases, which was even better to see. And so the really interesting thing from this data can really be highlighted on the area under the curve in terms of when we're looking at our concentration response curve, is that TrkC has a very profound dimerization response, or at least a profound coming together of our constructs, comparatively to that of TrkB and TrkC. And pulling out some pharmacological parameters here, so we have a look at our EC50s, to have a look at our potencies. We can see that our dimerization potency for each of our canonical ligands at its canonical receptor is fairly similar to one another, and it is just that profound dimerization that TrkC, in terms of the change in Brett, that is the atypical aspect. So once we kind of figured this out, it was a question of, well, is it actually TrkC? Maybe it's NT3. Does NT3 actually induce atypical dimerization? And how would we go about kind of deciding which one it is? And so to do this, we decided then to look at all combination of factors. So looking at TrkA with NGF, BDNF, NT3, and NT4 to see what's happening across the receptors and see if there's any differences between them. So if we have a look at TrkA here, we can see that NGF is coming out on top in terms of its ability to induce a dimerization response, but equally we are seeing that NT3 and NT4 are able to produce somewhat of a dimerization response, not as strong as TrkA, but it is quite notable that the potency for NT4 is quite strong, and even stronger than NGF in this case. And it's important to mention here that the pharmacological data for BDNF wasn't strong enough to pull an EC50 in this case, and that's been shown as ND as not determined. And so moving on now in terms of the TrkB data, we can see that BDNF and NT4 are producing, again, a very robust dimerization response. But interestingly here, NT3 was also able to produce a quite comparable dimerization response, which is somewhat atypical of what we thought. And then also, interestingly, NGF was unable to really induce any sort of significant dimerization in this case. Maybe we are starting to see that curve move upwards towards our top concentrations, but we couldn't quite see it at the levels we were using. And then finally, a look at our problem child, TrkC, then having a really, really robust dimerization response with neurotrophin 3 and BDNF, which was fairly atypical as it's not considered the canonical ligand for TrkC, but relatively similar potencies for these two ligands. And interestingly, I think it's important to note that NGF and NT4 had very limited dimerization response in TrkC, and this is interesting as BDNF did, and these two didn't. And so this figure here kind of gives a real nice idea of the real-time nature of the dimerization. So as we can see here, I've got TrkA in my top left, TrkB top right, and then on the bottom is our TrkC data. And so right now I'm just showing our top concentration, our 30 nanomolar of currently our canonical ligands. And then when we put on our non-canonical ligands, we can really see this disparity between them, as well as seeing the real atypical nature of TrkC. So kind of to conclude this section, we can see that TrkC has a very profound dimerization response. And I think it is important to note that NGF and NT4 were not able to induce any such dimerization and change. So moving on now from dimerization, I want to talk a little bit about trafficking, and this kind of posed the question, well, if TrkC is so different in terms of its dimerization, where else is it different? Let's have a look at the internalization of TrkC. So again, looking at a Brett-based assay, so we're looking at our donor and our acceptor, but now this time turning our attention to the C-terminus. So our Brett donor in this case is renylluciferase, and also we have a GFP construct that has a CAX motif. The CAX motif allows our GFP to remain membrane bound on the intracellular side, and therefore at rest our TrkB monomer should be in proximity of our TrkB, our donor, our renylluciferase should be in proximity of our GFP. And therefore, at rest, we're able to see a Brett response. But when we add in our BDNF, we're expecting that trafficking...
To go to the final bit, please.
Excuse me?
I'll give you 1 or 2 minutes more.
Surely I haven't had that much time. How much time has there been?
10 minutes.
Really?
Yeah.
Okay.
Go on.
Well, okay, I'm nowhere near through, sorry. Okay.
Don't worry, please go on, and if we have any time left, then we'll be able to do questions. Okay. If not, yeah.
Fair enough, okay. Okay, so yeah, we're looking at our trafficking response now anyway, sure. And we're able to see a change in Brett here, and we have the concentration response curve for this as well. I've done exactly the same for the dimerization. So moving on, I'll be quick now then. So we're now looking at this as we initially did with the dimerization data. And going through, we can see that, again, TrkC is looking quite atypical in terms of its trafficking data. Yeah, again, not seeing anything from NGF and NT4. And so I've kind of removed this now in terms of the area under the curve, in terms of its of the other ligands that we weren't seeing anything respond, and we can really see the atypical nature there. And then, yeah, final look then of what's going on in terms of our top concentration. So we're seeing TrkA, TrkB, TrkC. We're seeing this on the same scale now. So we're seeing that our TrkC has a really slow, limited trafficking response compared to that of TrkB and TrkA. And then NGF and NT4, again, not really producing any sort of meaningful trafficking response here. And then so finally, just to summarize, this is the kind of first real-time look at dimerization and trafficking at 37 degrees for these TrkB and TrkC receptors. I've been able to show that TrkA receptors can respond to non-canonical ligands, producing very unique dynamics. And then finally, and I think most importantly, is that TrkC shows the most distinct properties in terms of its dimerization and its endocytosis or its internalization. And finally, just to acknowledge is the team, my supervisor, Dr. Chloe Peach, and Professor Steve Hill, and also the rest of the members of the Peach Lab and our kind of cell signaling group at University of Nottingham, and also our collaboration project with the University of Birmingham, COMPARE, and finally, just the sponsors of my PhD, BBSRC. Thank you for listening.
Thank you very much, Ryan, for that. Excellent presentation. Do we have any questions? Just one? Yes.
Question?
Number 4, please.
Thank you, Ryan. It's really beautiful, loads of data, so well done. My question is really slightly broader. So what you're telling us is that there's less selectivity of these neurotrophins for the different tracks than maybe we thought, with NGF maybe producing this important dimerization for TrkB. And so what does that, what can we take from that where we're thinking about developing drugs that are specifically targeting sequestering NGF or targeting BDNF?
Yeah, it's a great question. And I think Physiologically, these will act kind of in their native environment a little bit differently. So it's important to remember that I've kind of stripped back all the details from the physiology. I mean, these were done in non-neuronal cell types, first of all, and then also the microenvironment has not been added in, so how that might affect things. But I think it's important to note from this that the NGF sequestering drugs, for example, it's important to note that other neurotrophins could impact, maybe to a lesser extent that I've kind of shown, less potent at these receptors. The other neurotrophins, such as neurotrophin 3, might have impacts at TrkA, although that might differ in disease states.
Thank you.
Yeah, a quick question, Ryan. Are there any structural features of TrkC that might explain the differences that you saw between it and the other TrkAs?
Yeah, it's a good question as well. So structural differences, in terms of its amino acid structure, there are differences. They're quite homologous in terms of how they naturally homologous, but I think you're right, the devil might be in the details in terms of where those differences are. Particularly, it'll be important to understand how the ligand binding region and if there are any discrete differences there. So I think that in itself could be an entire literature review to really understand where those specific amino acid differences are. But yeah, I agree that there probably are some really important amino acid differences that we should look into.
Yeah. Thank you very much, Ryan. And again, another round of applause for Ryan. Thank you. And we're going to move to our second speaker, who is Professor Samuel Fantin. Professor Fantin is from the University of East Anglia, where he holds a chair of pharmacology. And he's going to be speaking on structure-activity relationship of the allosteric effect of ivermectin at human P2X4 and GABAA receptors.
Great, thank you. Thanks for the committee for the opportunity to speak about our research today. So our research program focuses on this family of ligand-gated ion channels, which is a family of channels that is activated by extracellular ATP. So these channels are not to be confused with ATPases. This is a direct ligand-protein interaction. And these ion channels form as trimers, where often the monomer is in the shape of a dolphin. And we can see that the ATP binding pocket, the orthosteric site, forms somewhere between the head and the flipper domain, causing this head domain to clamp down and to open the channel. We know that there needs to be at least 2 molecules of ATP bind to this family of receptors to activate them, and the human genome encodes 7 P2X receptors, P2X1 through 7. So when these channels are open, they're non-selective cation channels, they excite neurons, they increase intracellular calcium, and they become desensitized to varying degrees dependent on the type of channel. So my interest is in one of these receptors, which is the P2X4 receptor, and looking at enhancing its activity for cardiometabolic benefit. So there's some prior information in the literature that might suggest this is a good idea when we look at its physiology and in blood vessels. We know that humans who carry a loss of function polymorphism in the P2X4 receptor have increased pulse pressure. We know that mice lacking the P2X4 receptor are hypertensive and have impaired vascular remodeling. We also know about the role of P2X4 antagonists impairing flow-mediated vasodilation and calcium signaling in endothelium, and that P2X4 is neuroprotective in some models of stroke. And the mechanism of action of its function in blood vessels is at the level of the endothelium, where the fluid force, the blood movement across the endothelial layer, triggers a release of ATP from the endothelium itself, which is sensed by this cation channel, P2X4, leading to elevation in calcium and predominantly production of nitric oxide. Also looking in the heart, we know that P2X4 knockout mice have normal cardiac function, but we know that overexpressing P2X4 in the murine heart can have cardioprotective effects. So some rationale for trying to boost the activity of P2X4. So we started to explore this with our industrial collaborators, Merck, using this compound, ivermectin, which is a Merck compound, MK933, used therapeutically as an anti-worming agent. Its target is actually a parasitic ion channel, a glutamate-activated chloride channel in the skeletal muscle of worms. But it's been known for a long time that this is an experimentally useful tool because it's a positive allosteric modulator of the P2X4 receptors. It's not an agonist, but it is a modulator. So you can get huge enhancement of the currents in P2X4 when ivermectin's present. But there's an issue with this compound, is it's not selective for P2X4, and other ion channel family members are known to be enhanced or directly activated by ivermectin, in fact giving rise to some of the anticonvulsant properties of ivermectin outside its antiparasitic activity. So we started off here with this molecule to try and understand its structure-activity relationship and to get some compounds that are selective for P2X4 over particularly the GABAA receptor and that can demonstrate some cardiometabolic benefit. So we collaborated with Merck, who generated a library of ivermectin analogues, so we could screen the SAR, undertook some molecular dynamic stimulation and high-throughput screening to identify hits at the human P2X4 receptor that were selective over GABAA and understand some of the chemistry. So I'm going to show some flavors of the chemistry here and some lessons we've learned about the chemistry of ivermectin. So ivermectin itself has this large disaccharide moiety that sticks out the side of the molecule here. One of the first chemical lessons that we learned is that you can completely chop this off with no loss in the pharmacological activity at all. So in all these slides, I'm showing the ivermectin dose-response curve for its allosteric effect against the test compound. So for example, milbemectin, which is identical to ivermectin, but without this disaccharide, to all intents and purposes, is the same as ivermectin. We also looked at some chemical modifications on that disaccharide moiety, and all the chemical modifications we added on were well tolerated. So we started to think why this might be and undertook some molecular dynamic stimulations to try and predict where ivermectin might be binding in the P2X4 molecule. Receptor rather. And what we've been able to do is identify a binding site down here actually in the transmembrane domains of the receptor where ivermectin binds reaching from one subunit across to the transmembrane domain of the neighboring subunit. And we've defined two subsites, subsite 1 and subsite 2. So the first subsite is responsible for binding the majority of this spirochetal group and the lower part of this benzofuran group, and the second subsite is important for accommodating this spiral butyl group, so that the molecule bends over into the neighboring subunit. And what we found is that when we look at how ivermectin binds here, that actually the disaccharide group points away into the internal cavity of the receptor, making very nominal molecular contacts with the receptor itself, probably telling us why the disaccharide unit is not required. We also found some minor chemical modifications, such as introductions of some double bonds within the spirochetal group, which massively enhanced the potentiation activity of ivermectin. So some examples here are abamectin and doramectin, where we found this subtle introduction of this double bond hugely boosted the activity of the molecule. And that's because we find that this introduction of a double bond produces some rigidity in the molecule and allows these molecules to better occupy subsite 1 and subsite 2, so a better spontaneous occupation of this area. We also found that additions to benzylfurone groups were quite well modified as well, and again, this is because of accommodation of these subgroups. So we started to build up some chemical information about how to build really efficacious compounds at P2X4, but then we wanted to learn a bit more about selectivity. So in these experiments, we explored one of the flavors of the GABAA receptor, and we looked at the response of ivermectin on it. And what's really interesting when you look in these experiments is that ivermectin itself is a full agonist at the human GABAA receptor. Some publications have suggested that this is the case, but we've formally shown this, and it has a comparable potency to GABA itself. So we used a dexamethasone-induced expression cell line of this GABAA receptor, and we can see without dexamethasone we get no response to GABAA or ivermectin. So these effects are dependent on the presence of GABAA, and this is a membrane potential assay. So we selected some candidates and undertook a large screen against the human GABAA receptor to identify some molecules that we knew had activity at the human P2X4 receptor, but lacked activity at the GABAA receptor. So we've now, I can't show you some of the structures of those today, but we've identified some molecules that potentiate the activity of P2X4 without touching GABAA. So importantly for us, we wanted to look at some of the cardiometabolic benefit and using some of our lead compounds. So if I can just remind you, the proposed role of P2X4 is in this endothelial shear stress response. So the movement of blood through the lumen should stimulate calcium signaling in the endothelium and leading to dilation of the blood vessel. So we could demonstrate that in my lab undertaking some pressure myography, and this is in some human arteries from human subjects undergoing abdominal surgery. So you can pressurize these vessels and measure their contractility and relaxation in real time. So what we're doing here is to contract up these vessels
10 minutes gone,
with a thromboxane A2 antagonist, and then cause fluid flow through the lumen of this blood vessel, which it induces this characteristic flow-dependent vasodilation, so characteristic of that fluid flow activating the endothelium. And what we can see with a number of our PAMs, that when we introduce P2X4 positive allosteric modulators into this system, that we get a huge enhancement of this flow-dependent vasodilation in human arteries. Furthermore, in rodent studies, we've looked in vivo applying some of these compounds in mini-pump, and we can see here in a angiotensin II induced model of hypertension. So we can see as the angiotensin is released in the mini-pump, the mouse becomes more and more hypertensive. But if we co-treat with some of our positive allosteric modulators for P2X4, then we get some protection against this angiotensin II induced hypertension without any effect of compounds on heart rate. So in conclusion, we know that ivermectin exerts some of its positive allosteric modulator activity through an intersubunit binding site at P2X4. We know of 2 subsites that are key determinants of that ligand activity. We've identified some of the core chemical scaffold for developing selective positive allosteric modulators for human P2X4 over the GABAA receptor. And we've got some human ex vivo and rodent in vivo work to show that some of these positive allosteric modulators have cardiovascular benefit, dilating arteries, protecting against hypertension. So finally, I'd like to finish by thanking past and current group members who've been involved in this and our industrial collaborator, Merck, also to Marcelo Bassetto at Cardiff for undertaking some of the in silico work with us, and collaborators in San Francisco at Merck. So I'll stop there. Thanks very much.
Thank you very much, Sam, for that excellent presentation. Do we have questions? Maybe I'm going to kick that off by asking you. So ivermectin is antiparasitic. What's the role of the disaccharide in that effect?
It's good. Yeah, so some people have tried to model how the ivermectin binds to that glutamate-gated chloride channel, and in that channel, the disaccharide does have some involvement in binding to the channel. We think across all the channels that it acts on, it has a similar mode of action, that it sits down in these transmembrane domains and keeps the pore open, preventing the channel moving into a desensitized conformation, and that's why you see enhancement of its activity. So certainly in P2X4, the disaccharide part doesn't seem to be important, but in the parasitic channel, it's known to be important.
Yeah, thank you. Number 2, please.
Yeah.
Hi.
Hi. Thank you for a very nice presentation. My question is not directly related to the cardiovascular, despite I'm working in that field, but I have observed that in epileptic patients, there's also an effect of ivermectin. And it's a bit surprising because one of the adverse effects is reported as it can induce attacks. But actually, I observed the opposite, but your slides nicely explain why. And really, my question is related to the P2X4, because I think it's also expressed in the vasomotor center.
Yes.
So when you examine the effects in animals, which one is most important? The one in the arteries or in the vasomotor center?
It's a good question. So we don't actually know a lot about the neurobiology of P2X4. It's profoundly under-investigated. We do know that there's some role of it in the mesolimbic system. There's people interested in drugging P2X4 for ethanol addiction, for example, but a lot of the mechanism is not fully understood. I haven't shown the data today, but we know that those positive allosteric modulators don't dilate the vessels in the P2X4 knockout animal, but we would like to get a bit more sophisticated in developing some conditional knockouts where we can start to address these questions, but at the moment, we don't know.
Yeah.
Okay. Number one, please, quick question.
We've got 7 P2X receptors. I'm particularly interested in P2X3, so does ivermectin work in other P2X receptors?
It's a good question. Yes, so in our hands, the answer is that for the P2X receptors, ivermectin is selective for P2X4. There's at least one paper in the literature to suggest that ivermectin might have a positive allosteric effect on human P2X7. Like you, we are also very interested in P2X3, and we were involved in Merck's development of gefapixant for the inhibiting sensory neuron function through antagonizing P2X3. We know for sure it doesn't have an effect on P2X3.
Excellent, thank you.
Thank you very much again, Sam, for that presentation. I am not sure whether Ms. Adia Lonsan is here. Okay, if she's not, we are going to move to the next presentation, which is going to be from speaker number 4. That's Dr. Declan McKernan. He is an associate professor in pharmacology at the University of Galway in Ireland, and he's going to be speaking on investigating the relationship between antipsychotic dose, inflammation, and cognitive function in schizophrenia, a moderation analysis. Welcome.
Thanks very much, and thanks for the opportunity to speak here today. So I think most people in the room might have some idea about schizophrenia. They might have heard about their positive and negative symptoms, about delusions, hallucinations, but may not be so aware of the cognitive dysfunction that's experienced by these patients, and in particular how debilitating it is in their day-to-day life. So my group is particularly interested in inflammation and how inflammation might affect these particular symptoms. So over the last number of years, there has been a number of different studies which have reported many different links between inflammation and schizophrenia. In particular, some of the strongest evidence comes from genetic studies, and about 10 years ago at this stage, the Psychiatric Genomic Consortium published their GWAS study and identified a region on chromosome 6 which contains many different immune genes, the MHC region. And you can see it here on this Manhattan plot, which contains the strongest signal. In addition to that, there's been many other lines of evidence that we've heard about, in particular, increases in plasma cytokine levels in these patients, increases in damage-associated molecular patterns, which are danger molecules released from damaged or dying cells. From imaging studies, we know that, particularly from PET imaging, that there's an increase in microglial activity in the brains of schizophrenia patients. In addition to that, there's structural abnormalities which have been linked and associated with the circulating cytokine levels. In addition to that, then, we have some epidemiological evidence which suggests that prenatal or perinatal infection may actually be associated with an increased risk of schizophrenia. And finally, from a pharmacological point of view, we know from trials that use anti-inflammatory drugs as adjunct therapies that they can actually reduce the positive and negative symptom scores in these patients. So we've been interested, as I said, in inflammation and schizophrenia, And one of the first things we wanted to find out was how individual cytokines may actually affect different cognitive domains in these patients. So we carried out a meta-analysis a couple of years ago, and what we found is that specific cytokines, most notably interleukin-6, TNF-alpha, IL-1 beta, and C-reactive protein, were able to have negative consequences in specific cognitive domains, most notably attention and processing speed, executive function, working memory, and visual and verbal learning and memory also. In addition to that, we wanted to find out, well, most of these patients are going to be on antipsychotic medication, if the antipsychotic medication had an actual effect on the levels of these circulating cytokines. And again, we went to the literature and we were able to find that in particular the second generation antipsychotics, which are most commonly used nowadays, had a specific effect on circulating cytokines, most notably risperidone and the drug clozapine as well, which were able to reduce the levels of interleukin-6, TNF-alpha, and IL-1 beta as well. So this comes to the part where we're, I suppose, interested in, which is around what is driving this inflammation in these patients. And one potential route by which this could happen is through increased expression and activity of toll-like receptors. So toll-like receptors are most notably, I suppose, known for their ability to detect microbes. These are plasma membrane receptors. They're also expressed on endosomes at various different levels throughout the body. So they're able to recognize, as I said, components of bacteria, viruses, and some fungi as well. They're also, interestingly, able to detect these damage-associated molecular patterns that are released from dying cells. From this, they're able to initiate inflammatory pathways, and this results and culminates in the release of cytokines and type 1 interferon. So we know for many years that many different chronic inflammatory conditions have dysregulation in these particular pathways, but in more recent years, this has also been linked with some neurological and some psychiatric conditions as well. So in our study, we hypothesized that TLR activity may potentially be dysregulated in these patients, that the altered activity may be associated with some of the cognitive dysfunction that I previously mentioned, and that potentially as well the antipsychotic medications that these patients were taking may be able to moderate this relationship. So in terms of our aims, we set out to quantify the TLR expression levels in the peripheral blood of schizophrenia patients, to do some ex vivo stimulation with TLR ligands and to calculate or to quantify the TLR activity, and then to investigate the relationship, if any, between these measures and the cognitive symptoms, and then finally to investigate if antipsychotics, and in particular the dosage of antipsychotics, was able to moderate this relationship. So to do that, we had to recruit, we had to recruit over 200 healthy controls and nearly 100 schizophrenia patients. These were recruited with strict inclusion and exclusion criteria. They were chronic stable patients, all of them on medications. They didn't have any other chronic inflammatory illnesses. They hadn't taken any anti-inflammatory drugs when they were recruited. And from this, we were able to do blood draw and measure the plasma cytokine levels. We also took some blood to do some genotyping and some RNA analysis and to do some quantitative PCR. And then finally, we did some blood stimulation studies with known ligands of some TLR receptors. In addition to that, the patients all underwent cognitive testing, most notably for full-scale IQ, for attention and processing speed, for verbal learning and memory, for visual learning and memory, for working memory, and finally then for social cognition as well. In terms of our demographic data, we didn't see any differences in the sex distribution between controls and patients. There was a significant difference between the ages of the participants and the BMI, and most notably, there was a significant decrease in the cognitive functioning of the patients, as you might expect, between the patients and the controls. We then looked at the medications that were being taken by the patients, and all of them were on some type of medication. The vast majority were taking at least one antipsychotic, with some patients taking 2, potentially even 3 antipsychotics. And so if we were going to carry out any kind of an analysis, we needed to normalize this, and to do that we used the defined daily dose method and calculated the olanzapine equivalents for each of these patients. People might be wondering, were they taking any other medications? I mentioned they weren't on any anti-inflammatories, but some were taking cardiovascular medication and also antidepressants as well. So we were able to show that there were elevated levels of cytokines, as was previously demonstrated in the literature. We were also able to show increased expression levels of TLRs and increased TLR activity. And when we did some statistical analysis using models of multiple linear regression, we were able to show that there were increases in TLR2 and TLR4 activity, and that these increases were also associated with the cognitive deficits that we showed already. In particular, TLR2 activity was related to visual learning and memory, causing a significant decrease, and also working memory. And for TLR4 activity, this was associated with a decrease in social cognition. We then moved on and wondered, well, is there any kind of a relationship here, a statistical relationship? And to do that, we carried out a mediation analysis, and we were able to show that TLR activity is associated with specific cognitive deficits. In some cases, there was a partial mediation, and in others, there was a full mediation. So most notably, there was a link between TLR2 activity and attention and processing speed, as well as working memory. And there was a full mediation between TLR2 activity and verbal learning and memory and full-scale IQ. And finally, then, there was a relationship between TLR4 activity and full-scale IQ also. So moving on to the drugs then, as I mentioned, we had to calculate an antipsychotic equivalent, so the olanzapine equivalents for all of these different antipsychotic medications that the patients were taking. And what we're able to show is that the antipsychotic dose actually affects the TLR4 activity in particular. We were able to calculate this more specifically, and we were able to show that for every 1 milligram increase per day taken by a patient, that this actually led to a change or an alteration in the peripheral TLR4 activity. We were also interestingly able to show that the antipsychotic dose was able to affect specific cognitive domains. And there's a bit of controversy about this in the literature, and we were able to show for our particular cohort of patients that it was able to target specific domains here, in particular the full-scale IQ, the attention and processing speed, and social cognition also. And again, at the dose level, we
Just to let you know, 10 minutes gone.
We were able to show that for every 1 milligram per day increase in antipsychotic dose, that it affected the scores for these particular domains, like full-scale IQ, attention processing speed, and social cognition. So having demonstrated that the antipsychotics could affect the TLR4 activity and also the cognitive domains, and the fact that we'd already previously established that TLR activity was associated with cognitive domains, we wondered whether the antipsychotic dose could moderate the relationship between the TLR activity and cognition. So finally, we carried out a moderation analysis, and while on the overall picture there was a significant difference between TLR4 activity and attention and processing speed, when we drilled down and looked at the conditional effects and looked at the level of dosage, there did not appear to be a significant effect. So in conclusion, we were able to say that the antipsychotic dose, while it was affecting TLR activity and cognitive dysfunction, it was not able to moderate the relationship between TLR activity and the cognitive domains. So in conclusion, we showed the presence of low-grade inflammation in these patients. We showed that the antipsychotic dose was able to affect the TLR activity, but it did not moderate the relationship between TLR activity and cognition. So finally, I'd like to just acknowledge, in particular, a PhD student, Sahit, who did the majority of this work, my iRelate team members in the University of Galway and in Dublin, funding from the European Research Council and from the Hardiman Foundation in Galway, colleagues in Galway as well, and finally, thank you to the BPS for allowing me to speak here today.
Thank you very much for your nice presentation. Yeah, that's great. Do we have any questions? All right. Can I ask, do you think there is any role for genetics in some of the profiles that you saw?
Yeah, definitely. So that's actually the next step in our study. So we've already started to genotype these patients, and I won't spoil the story, but we're seeing some interesting findings with regards to the TLR pathway.
Yeah. And are you thinking of taking this beyond your own center in terms of?
Yeah, so definitely that's the next step, and I suppose that'll involve a bit of grant writing and collaboration. Yeah.
Yeah. And how big do you think the problem is of people given antipsychotics and who have all the cognitive issues?
So again, as I said, this is quite a controversial area in the literature, and about 2 months ago there was a network meta-analysis published which showed that it might actually be antipsychotic specific. So what's notable about our cohort is that the majority of patients were taking clozapine, and actually in this network analysis, clozapine was the one that had the most negative effects on cognition, along with haloperidol, which is a first-generation antipsychotic. Whereas some of the other newer second-generation drugs, like quetiapine, for example, and risperidone, don't seem to have those negative cognitive effects.
So it means, or it seems that partly the problem is with the drug themselves, and partly with patients in any way.
Yeah, I think it's going to be drug specific.
Yeah. All right. Do we have any more questions? No. All right. Thank you very much for that presentation. Yeah. So we're moving on to our fifth speaker, who is Mr. Thomas Pritchard. And Thomas is a second-year PhD student at the Department of Pharmacology, University of Cambridge. And he's going to be speaking on Oncostatin M, activates nociceptive neurons innervating the murine gut.
Thank you very much. Okay, so if you see from my title, if we start and talk about nociception in the gut, that makes you think of the substantial gut pain, which naturally to me makes me think of inflammatory bowel disease, which is a disease predominantly composed of ulcerative colitis and Crohn's disease, which whilst having large states of inflammation in the gut, also these patients really suffer from chronic visceral pain, of which there is a real dearth of effective analgesics available, with really the only solutions being either NSAIDs, which might not be so effective, all the way up to opioids, which for a chronic disease have natural problems with addiction, as well as causing gut-related problems such as constipation. And so if we look at a natural starting point, if you want to look at places that might provide insights into potential analgesics, you want to look at the states of inflammation, which is really a predominant part of the disease. One pro-inflammatory receptor for a pro-inflammatory cytokine that seems to be very prevalent in this disease, you can see, is actually the Oncostatin M receptor, which is a member of the IL-6 family. And as you can see here, in the transcriptomic data taken from biopsies of inflammatory bowel disease patients, you can see that in Crohn's disease and ulcerative colitis, there is a significant upregulation in the Oncostatin M receptor as opposed to healthy patients, which does seem to give an indication that there may be a role to play for Oncostatin M-related signaling in this pathology. But what this doesn't tell you, though, is that these are biopsies taken from a site of inflammation in the colon, but these biopsies will contain lots of different cell types. And so to get a greater appreciation for any role Oncostatin M signaling might be having in the sensation of in nociception, we want to look at the colonic sensory neurons. And so in some single-cell RNA transcriptomic work done by Hockley et al., we can see that in the nociceptive subgroups of the non-peptidergic and the peptidergic sub-A and B subtypes, we can see a really substantial expression of the Oncostatin M receptor. And within these subtypes, if we look at the co-expression of the Oncostatin M with TrkA1, which is a mechanosensitive ion channel, TrkV1, which is, as you'd have heard previously in Professor Brain's talk, is the heat-sensitive ion channel. And also, if you look in the IL-6 ST receptor, which is a murine homologue of GP130, which is obligatory required for the signaling, the transduction of an OSM signal, we can see that there is a significant number of cells here that seem to be co-expressing these receptors with OSM, which gives an indication that they may have some involvement in transducing an OSM-related signal in the context of colonic sensory neurons. And so the question to this talk I'd really like to answer here is, first of all, I'd like to raise the question of does OSM actually show a functional role in colonic sensory neurons? And the way I'll be measuring this is by looking at calcium flux, and so the activation of these neurons. And if this is true, do we see a change in the any change if we start to investigate any role for TrkA1 and TrkV1? And finally, and most and quite importantly, this was, if these things show true within dissociated dorsal root ganglion neurons, is this actually true if we look to the nerve terminal where the site of inflammation is occurring? And so first of all, by doing, as I said, by undertaking some calcium imaging of dissociated dorsal root ganglion neurons taken from the T12 to L5 vertebrae of a mouse, which is the area it should be innervating the gut, we can see that perfusion of 13 nanomolar of Oncostatin M does seem to show a drastic increase in the proportion of responsive dorsal root ganglion neurons. And furthermore, if we look into the size of some of these responsive cells, but they seem to be much smaller than the non-responsive cells, falling within the 200 to 800 micrometer square size range, which is highly indicative of nociceptors. And furthermore, if we look at the overall response of our cultures to the TrkV1 agonist capsaicin, we see it as a significant proportion of responders, indicating that there is a good population of TrkV1 positive neurons within these cultures. And so expanding on this, having seen that we seem to direct response to Oncostatin M, if we look to antagonize and block TrkV1 and TrkA1, as you can see here, we do see an ablation of this increase in response, as opposed to vehicle. And so therefore that seems to give an indication that the rise in intracellular calcium we see in response to Oncostatin M may be rising through and entering the cell through either TrkV1 and or TrkA1. But we don't really know necessarily know the mechanism how this might be acting. But as an interesting aside, if we look in the context of a potential connection between these two signaling pathways, between the canonical signaling of the Oncostatin M signaling pathway and these non-specific ion channels, we can see that if we actually block PKC, which is known to have interactions with the internal domains of TrkV1 and TrkA1, we can see that if we block this, we can see a similar reduction in the quantity of responsive neurons, which may give an indication that PKC might be involved in sort of sensitizing these ion channels or allowing them to maintain an open conformation. So having looked at this in the periphery, it's really important now to make sure we can verify some of these results and make sure it stands up if we look into the nerve terminal. And so a very useful technique we used for this in our lab, and that was some of this work done by Dr. Rohit Gupta, as you can see here. One thing you can do is by taking the colon out of the mouse and peeling away the tissue to reveal the lumbar-splanchic nerve, which is the nerve that innervates the colon. If you suck this nerve up into a microelectrode, you can then record the voltage from create a circuit and record the voltage from this nerve, and then with the application of drugs, you can look for changes in spike rates, and so therefore changes in the action potentials. And so if I just show briefly here, we can see that on this graph on the right-hand side, we can see a really slow but still present increase in response of afferent nerve firing in response to Oncostatin M. But if we want to look at this in a more clinically relevant setting, one thing to do would be to look at what happens if you distend the colon. And so this is naturally quite a common occurrence to be occurring in inflammatory bowel disease patients. And as you can see, if you do a ramp distension, you can distend this colon, you'll get repeatable increases in spike rates in the action potential firing. However, if between two of these distensions you apply some of this Oncostatin M, we can see that it seems to sensitize the following distension response to create a substantially increased spike, which seems to give an indication that Oncostatin M might be playing some sort of role in the mechanosensitization of the colonic sensory of the lumbar-splanchic nerve innervating the colon. And to look at this in greater detail, we might another method of doing so is to apply an agonist to the bath solution that the colon and its nerve are sitting in. As you can see, if you apply this ASP with pre-incubation of a vehicle, which is an agonist to TrkA1, we can see that you see a visible spike, an increase in spike rates, and therefore action potential firing in the nerve. However, if you pre-incubate the colon with some Oncostatin M, we can actually see that we seem to see a much greater increase in the spike rates, and this seems to hold over time, which gives some substantiation to the the role in mechanosensitization that Oncostatin M seems to be having in the lumbus blanket nerve. And also, if we look at if we repeat this same experimental protocol but with an agonist for TrkV1, and so the capsaicin, as you heard about earlier, we can see that whilst you don't see much of a change in the increased spike rate, you do see an ablation of this rapid desensitization, which is characteristic of a TrkV1 application, which does seem to be will show a much greater increase in nerve activity over time in response to a pre-incubation with this Oncostatin M. And so, in summary, I hope I've shown some data here that shows a potential role that Oncostatin M might be having in a rise in intracellular calcium within dissociated dorsal root ganglion neurons, and so therefore indicative of action potential firing, and that there seems to be roles for TrkA1 and TrkV1 in this process, and also that this really holds up when you look at when you record directly from the lumbus blanket nerve, which gives an indication that this isn't something specific to the cell body, and this is actually happening within the tissue. And so some future questions that might arise out of this that would be really interesting to answer to substantiate some of these findings is, because we don't really know the connection between activating the Oncostatin M and GP130 receptor complex and causing an rise in intracellular calcium. With the idea of raising these questions is can we find something that could be a potential target for future analgesic research? And so something that might be a possibility here is looking at TrkC, which is one of the Janus kinases involved in the transduction of the OSM signal. Because as you may know, that there is it's commonly found alongside JAK1, which has been looked at some targeting in the past in terms of potential analgesics, but unfortunately, with the prevalence of JAK1 in terms of pro-inflammatory signaling, blocking this response does seem to cause some immunosuppressive side effects.
10 minutes gone now.
Thank you very much. However, there may be a possibility in having a more targeted approach towards TrkC, which may not have these immunosuppressive problems. And so along with these other things, but in press for time, I thought I might show you that I've actually been looking at this question. And so also, as you can see here, in repeating this normal Oncostatin M protocol I showed you earlier with the calcium imaging data, if you apply a PanJAK, this pyridone 6, we do see an ablation of this response to Oncostatin M, which does track with previous data as we're blocking all these Janus kinase transducing this intracellular signal. However, if you use the TrkC specific ducravastatinib, was a mouthful, we also see a similar ablation of this response, which seems to indicate that you might not necessarily need to block the JAK1s particularly to attenuate this Oncostatin M initiation of activation within sensory neurons. You might be able to do it purely by applying a specific block to TrkC. So I'd just like to thank you, the rest of the group I work with over at Cambridge, and to my supervisor, David Bulmer. Thank you very much.
Thank you so much, Thomas, for that. Excellent. Well done. Do we have any questions at all? Can I ask a few questions? So when you introduce the TRPV1 antagonist or the TRPA1 antagonist, you attenuated the effect of OSM with regard to increase in calcium, but you didn't abolish it.
No,
so do you think there are other contributors to what you saw?
So a natural question that will arise from that is because OSM isn't an agonist for TrkV1 or TrkA1, so blocking it and then seeing a reduction in the OSM signal is kind of interesting because it feels like there should be some sort of endogenous ligand going on for these channels. But with regards to not completely ablating the OSM signal, it's possible that whilst we do see quite substantial co-expression with OSM in populations that co-express TrkV1 and TrkA1, it's not a complete overlap, and so it's possible that there's still some sensory neurons being recorded which, whilst they are receiving an OSM signal, are not necessarily co-expressing these receptors, and so blocking it might not be totally ablating the total signal.
Yeah. And in terms of the translational relevance of the work, is there any evidence that the nociceptive neurons in the murine gut behave very similarly to the human
I believe the anatomy is very similar, and so there's no obvious areas where you might think that this might cause a translational issue, like you say, once you take this into human trials. However, there is a lot of interest in seeing if we can replicate this within human dorsal root ganglia cells to provide a greater reassurance on that part. But no, this is naturally a close approximation and not perfect.
All right, and what's the next thing you're doing now?
So I guess there's personal interest of mine is working within the grounds of trying to identify the role of TYK2 particularly. As we saw there seems to be quite a role for that, which I think might be provide use in the future. So I quite like to see how this is linking along to causing the rise in intracellular calcium, and so narrowing down some of this molecular pathway and how it might interact with TrkB1 and TrkA1. I think that's going to be quite important for progressing this work further.
Yeah, thank you so much.
Thank you very much.
Excellent. And we are moving on to the last but not the least speaker for today, and that's Miss Miriam Salahuddin. I believe she's here, and she's from the University of Manchester. She's a PhD student there within the Neuroscience department, and she's going to be speaking about innovative cellular therapy for stroke. So primed mesenchymal stem cells, mitigating neuroinflammation and promoting neuroprotection. Over to you.
Okay, don't start the timer yet. I need to stretch. I'm tired of sitting. How many of us here have seen a stroke survivor? Family member, friend, neighbor? How many of us? Good. So my entire PhD is focused on improving clinical outcomes after stroke using cellular therapy. And the statement you read on the first slide is actually more of a statement of optimism rather than an exaggeration. So good evening, everyone. Today, I'm going to be telling you a little bit about my PhD research, and with focus on the neuroinflammatory and neuroprotective potential of cellular therapies. Now, what is stroke? Stroke is actually a neurological condition that is characterized or that occurs as a result of interruption to blood flow in the brain. This interruption could be as a result of bleeding somewhere in the brain, in the case of hemorrhagic stroke. It could be as a result of blockade of a blood vessel supplying blood to the brain, in the case of ischemic stroke. Now, of these two stroke types, ischemic stroke accounts for more than 80% of all of them. Now, even though in the last decade, there has been a decline in mortality from stroke, it is still the leading cause of permanent disability, and it's been identified as one of the most frequent causes of dementia in developed countries. Unfortunately, there's only one drug for the treatment of ischemic stroke, and that's a recombinant tissue plasminogen activator. Typical example is alteplase and tenecteplase. What this drug do is to lyse blood clots within affected blood vessels so that reperfusion can be ensured. However, it's got a very short time window of between 3 to 4.5 hours. And what this means is if a patient presents to the hospital outside this time window, such patient is not going to benefit from therapeutic effect of alteplase. And even if a patient presents in time, the patient can suffer life-threatening side effects, such as hemorrhagic transformation, where you have bleeding in the brain. A typical alternative to RTPA is the use of endovascular thrombectomy. Here, there's surgical removal of blood clots from large blood vessels, if these are the blood vessels that are affected. Emphasis on large blood vessels. So it means if stroke is caused by occlusion in smaller vessels, that patient is not going to benefit from ET. This is one major drawback. This is in addition to the fact that there's no assurance of no reocclusion in the future, aside the fact that it's very expensive and it requires experts to carry out. So you'll all agree with me that we currently need a drug that is all-encompassing. It's safe, efficacious, affordable, and of course, widely applicable. And so in our lab, we're looking at using primed mesenchymal stem cells So what are MSCs? These are adult-derived multipotent stem cells that are capable of differentiating into various cell types. And we're using them because there's minimal ethical consideration when you're getting them. All of us hate ethics committee. Their requirements are always too much. In addition to having minimal ethical consideration, you get them in almost every tissue of the body. Watkins jelly, even menstrual blood, adipose tissue, peripheral blood, name it, you find them there. They are also capable of differentiating and transdifferentiating into various cells. They are capable of fixing themselves when they are injured. And lastly, there's a pool of preclinical trial results showing their effectiveness. So why are we priming them? I like to define priming as the process of immunizing cells. And I use the word immunizing because the principle of immunization and priming are quite similar. So when you immunize an individual, what you do is to introduce attenuated version of a deadly microorganism here, so the person's immune system is sensitized to produce arsenals that can fight this deadly organism when the real threats present. So in priming, what you're doing is to increase the survivability and the therapeutic efficacy of mesenchymal stem cells in a target condition. In addition to that, priming has been shown to increase their longevity. It's been shown to enhance their ability to migrate from the site of administration to site of injury and ensures they stay there to perform their action. It also increased secretion of tropic factors, new nerve cells, as well as new blood vessels. And these last 2 points are actually very relevant in the context of stroke. So we hypothesize that because ischemic stroke is associated with hypoxia and inflammation, we hypothesize that if you prime bone marrow that you derive from humans, if you prime them with both inflammatory cues, such as cytokine, and hypoxia, you're going to be enhancing the therapeutic potential of MSCs. And the research aim is to evaluate these prime cells in mitigating inflammation and ischemic damage. And to do this, we're using 2 models. The first one is to check the anti-inflammatory effect. So what we do is to culture human bone marrow-derived mesenchymal stem cells. Once they are confluent, they usually look like that. Once they're confluent, we split them, and we prime them with either cytokine, IL-1 alpha, or hypoxia, using hypoxia mimetic cobalt chloride, or we prime them with both. And when we're done, we collect conditioned medium over a 24-hour period and treat BV2 cells, which are microglia cells. We treat them in the presence of this conditioned medium and LPS, which is a neurotoxin that induces inflammation in the cells. Thereafter, we collect supernatants and analyze for certain biomarkers of interest. And to check for the effect of these prime cells on neuroprotection, we do something similar, prime them in a similar way, but instead of exposing BV2 cells to LPS, we expose them to oxygen and glucose deprivation for 2 hours in the presence of conditioned medium. And after that, we measure the effect of this treatment on OGD and OGDR injury. Now, these are my results. I'd like you to pay more attention on those bars within the red boxes. We realized that when you expose BV2 cells to inflammation in the presence of conditioned medium from primed MSC, there was significant decrease in the production of pro-inflammatory cytokine, IL-1 beta, and IL-6, with a corresponding increase in anti-inflammatory cytokine, IL-10. This is in addition to cytoprotection. Even though this is not statistically significant, treating BV2 cells with conditioned medium in the presence of LPS reduced the amount of cell death experienced, even though not statistically significant. In the second model, similar result was almost replicated. Almost because, except for TNF-alpha, there was a decrease in production of IL-6 and an increase in production of IL-10. Now, TNF-alpha production was increased in cells that were treated with conditioned medium from dual-primed MSC. Dual-primed in the sense that the MSC was primed with both cytokine and hypoxia. And now we know TNF-alpha is neurotoxic, but there are researches showing that they can be neuroprotective, and when they are neuroprotective, they do this via many mechanisms, including preventing apoptosis. We're suggesting that it could be here, TNF-alpha could be acting as a neuroprotectant because it reduced significantly cell death. That was the only one that was statistically significant. All right, so to check for the effect of primed MSCs on the production of MMP9, we did immunocytochemistry. All right. MMP9 is known to be upregulated during ischemic stroke and is being associated with cerebral edema as well as blood-brain barrier damage. So we checked for the expression of this protein, and we realized that if you look at the second plate, these are cells that were exposed to only OGD without treatment. You can see beautiful pink lights around them. There was massive expression of MMP9. But for those that were treated with conditioned medium, this has been downregulated. It's just surfacely expressed. So in conclusion, we'll say our preliminary data are showing that priming mesenchymal stem cells with both hypoxia and inflammatory cytokine offers a great advantage because it increases their therapeutic potential in the fight against neuroinflammation and ischemia. So I'd like to thank God Almighty for making this possible, my supervisors, family and friends, and most importantly, the University of Manchester President Doctoral Scholarship for funding this project. Thank you for listening.
Thank you very much for that. Have we got any questions?
Please, there should be questions because this is, second year of my PhD.
I've got questions for you. Yeah. Yes, if anybody else has questions. Okay. So let's start with your models, the LPS-induced inflammation and OGD. And you got all these responses. How robust are those models, or what are some of the limitations?
A lot of limitation, and this is why these experiments are the starting point. We're using BV2 as a cell line. First, it's obtained from mouse, and then it's immortalized cell line. It's got a lot of genetic variation that is far away from human. And so, because we've got positive result now, we're moving towards using primary human cells to do something similar. In addition to the fact that we're using cell lines from mouse, the OGD we didn't use hypoxia chamber, we're using hypoxia mimetic, cobalt chloride.
Yeah.
And that could be a limitation. Even though I've seen publication where the use of hypoxia mimetic was touted to be better than using hypoxia chamber because there is more stable induction of hypoxia using cobalt chloride, according to the papers. So going forward, we'll be using primary human cells, and then we'll be doing more molecular studies. So if it shows promise as a new anti-neuroinflammatory agent, we'll be looking at mechanism of action and many more.
Yeah, thank you. And do you know why it's been very difficult to find anti-stroke drugs for many, many years?
Maybe because it's a complex condition with so many things coming into play, neuroinflammation, oxidative stress, apoptosis, a lot. And I think it's because it's a multifactorial disease. That was why I suggested to my supervisors that maybe we should use conditioned medium, because I believe it's a cocktail of biochemicals. Who knows? You can find things that can act on different pathophysiology of stroke within one cocktail, and then something good might come out of it.
Yeah, and you're planning to translate this into clinical utility.
Yeah.
You mentioned something during your presentation about the cost of the current interventions. Yeah. So do you think that if this gets to the clinic, we will be able to solve the problem of huge costs, or is it going to be a challenge?
I think so, because of the wide availability of these cells. I advise all women in the hall, if you're healthy, you can just start isolating MSCs from your menstrual blood. Yeah, because you can find them everywhere. Hopefully, when we finish the research, we can tell what is beneficial and what is harmful, and then produce something useful to human. Bedside translation, yeah.
All right. Thank you very much for that. And another round of applause for her. So I want to thank all the speakers for their excellent presentations today. And again, let's give a round of applause to all of our speakers. Thank you. Before we bring this session to a close, just to remind us again that we're encouraging us to visit the booths of the sponsors and the partners. We are grateful to them for all the contributions to Pharmacology 2024. And so you can see all of those different partners up there. So we want to thank you too for attending this session, and that's the end of our session. Hope you enjoy the rest of the day. Thank you.